Good morning. I'm Jessica Lovell. Welcome to the Morning Medical Update. Anna Campistol faced a very bleak diagnosis. Technically speaking, stage 4 stomach cancer is considered non-curable, but today she has what's called no evidence of disease. Reporter Janine Kiesling explains that the first doctor Anna saw actually blamed her symptoms on heartburn.
It was November of 2021 when Anna Campistol was sent home with that heartburn diagnosis. By the time she found a doctor willing to dig deeper, it was May of 2022, and Anna now had stage 4 gastric cancer.
I could still cry today. It was terrible. Yes, it was. No, my world came upside down.
Anna Campistol is from Spain, but now lives in Olathe with her husband and 2 young children. She was terrified by the diagnosis and what doctors said about it.
They told me they didn't know the outcome. They were not very optimistic either.
Friends told Anna to get a second opinion at the cancer center. That advice, Anna says, saved her life.
Out of amazing, like over the world. I mean, they never expect. I mean, this is something that, no, I mean, my cancer was a stage 4. It was already in the lining.
Anna says her doctor at the health system was confident Anna could beat this, but to do so, she would need a gastrectomy. That's when doctors remove your stomach completely.
Well, I was shocked, to say the least. I was like, my question to him was like, can I live without stomach? And he's like, well, yes. As a matter of fact, you can even have a normal life. That would be the best outcome under your diagnosis.
For Anna, there was no decision to be made. This is what had to be done if she wanted a chance to survive. And Anna knew her doctor, Dr. Mazin Al-Kaspouls, was the one to do it.
This can be done, and for me, he has a big heart, and he's a lifesaver.
And we are so glad to have Anna join us here at the table with us today. Good morning, how are you?
Good morning, I'm doing great.
I love to hear that. Also in studio with us are 2 of your doctors, Dr. Weijing Sun. He is an international expert in gastrointestinal cancers, as well as Anna's medical oncologist. Of course, Dr. Mazin Al-Kaspouls, always good to have you here with us. He is a surgical oncologist who discovered how far Anna's cancer had actually spread. And then you are the one who performed the operation that has gotten her to where she is today. So we're going to talk all about how this is working. Thank you all for being here. We'd love to have you all back together, reunited. This is really an incredible outcome considering the original diagnosis. Anna, first of all, you said you're doing well. Tell us a little bit more about that, how you're doing.
Well, I can do a normal life now, and I'm so thankful. I think about my doctors every day. They brought me back to life. I am very happy to do normal life again, to go sports with my kids, to go to a restaurant, to just not have to think about chemotherapy. Was very hard, but it can be done. Dr. San always was optimistic. Dr. Al-Kaspouls gave me the strength I needed in the hardest times. So I always know I'm in good hands.
So when you say back to life, you mean physically being able to do the things, but also mentally not having to think about what this outcome could have been?
Certainly.
So we mentioned when you saw your physician, they thought you had heartburn. So describe those symptoms that you were feeling, and then I want to ask your docs why that would have been confused for that.
Absolutely. So it started like chest pain. It was on a scale 1 to 10, maybe 7-ish. So I went to the doctor to make sure everything was okay. I've never had heartburn before, so I didn't know what we were talking about.
And when you say you went to the doctor, did you go to an emergency physician, or did you made an appointment?
Doctor, okay. Yes. So they ran a heart test. It was okay. They did a blood test, and it was a little bit low in iron. But that was pretty much it. They told me Pepsid would make it.
So you needed a lot more than Pepsid. Dr. Sun, tell us why, well, first of all, Anna did the right thing going to see a physician, thinking it might have been heart-related, heartburn-related, maybe something simple, but why would they have confused that, and is that normal?
Yeah, the question is there are common things which called the GERD, which is reflux symptoms, bother a lot of people, especially when you're eating not regularly or eating not as much as you should do, and then you do more than you do. That happens, called common symptoms. However, cancer sometimes, many times, is those common symptoms are not reliable. There is no particular sign for the cancer sign, but those symptoms could be shared with the other disease. But more important is the physician and the patient. If regular symptoms, quote unquote regular symptoms, is too long or too severe than usual, you need a suspicious for some other things instead of relying quote unquote common sense. So now the special common sense is you need to do is see your gastroenterologist, and then many times you can do is a scope, which means you put a camera down your throat to look at your stomach. So you have a high suspicious when things are not common or not regular anymore, especially timing more than 2 or 3 weeks or months, then you really need to think about those symptoms, especially for younger people.
Anna, you learned this is not heartburn. You now get the news that you have cancer. What was that like, and when did you make the choice to come to the University of Kansas Cancer Center?
Well, when I learned that it was cancer, I mean, I couldn't believe it, and I was shocked, and of course I would never thought it was even less, stage 4. So yes, I talked to some friends of mine who are in the medical field who have been amazing. Radhika Gupta is just so, I mean, she has also been supporting all the step of the way. And yes, she's, and other friends told me KU Med would be my best choice, and absolutely, I have to agree. I didn't know KU Med. I've never had any other health issues before. So this was our first experience, and it has been the best.
So she comes to the Cancer Center. Dr. Sun, what type of plan did you put together for her and her treatment? What lied ahead?
Yeah, so the question is, first, when Anna came to us, she has a very unusual cancer, stomach cancer. We call it nitidoplastica, which means her early symptoms actually, besides reflux, and also is what we call early satiety, which means even she does very small portion, immediately she feel no longer hungry, or full of stomach, just small portion of food. Those kind of early symptoms, and those symptoms made the patient unique in the situation. And when I saw the patient, saw the Anna, she already have those endoscopy done, had a CT done, which you see some lymph nodes around the stomach already involved. So by initially, before Anna see Dr. Kaspers, we already know she's called at least a locally advanced disease, means the lymph nodes around the stomach are involved. So the best knowledge today is when we're still on diagnostic processing, we need a starting treatment as soon as possible to save the time to move her to potential possible surgery. So that's very important. And we have a lot of clinical trials from United States, from Europe, from Asia. We know the sooner we give a chemotherapy, the sooner we use the best chemotherapy we have today, and the sooner we adding on immunotherapy to the chemotherapy, we have the best chance. So we decided of a standard chemotherapy, very strong chemotherapy combination on the one hand for anti-tumor, and including immunotherapy, which is the best science today we have today up front the surgery, and while we still have to consider diagnostic processing, which is called laparoscopically.
So we're going to talk about that. Dr. Alcaz, that's where you come in. When we talk about surgery, you come in and work your magic with these patients. You did laparoscopy. Tell us a little bit about that and how you worked to help get Anna back to where she needed to be.
Yes, there are two kinds of stage 4 for stomach cancer, in any organ in the belly. One type of stage 4 is the one we always think about, where the cells, the cancer cells, get in the bloodstream. They travel in the bloodstream, then they exist in the bloodstream maybe, and also they get into the organs, like the meat of the organ, like the liver or lung. There's a different kind of spread, of stage 4 spread, where the actual tumor penetrates through the wall of the organ or or the bowel, and it sheds cells almost like seeds, and those seeds sort of float around in the abdomen and they land on the surfaces of the organs. Unfortunately, things like CAT scans and PET scans are not very good at catching that kind of stage 4, the second kind of stage 4. And we know that in stomach cancer, in general, in stomach cancer, if you have stage 4, surgery, meaning getting the stomach out, is not even in the management. So when I did that laparoscopy, I did note some of these dots, which made her stage 4. And then her and I had a conversation about HIPEC. It just turns out that this hospital is a HIPEC center. And we do a high volume. And although it's very controversial in stomach cancer, given that she was young and she only had a little bit of those dots, I thought it would be definitely reasonable to do it on her. She has a long life to live, obviously. She has a lot to live for. And she's healthy and young, and you know, she can handle it.
So let's talk a little bit more about HIPEC. Exactly what is that?
Yeah, so HIPEC is that kind of spread I just mentioned. And, oh yeah, I can see it up there. The kind of spread I just mentioned. So there are two parts to the operation. One part is actually going in and removing the tumors. There are 3 ways you can remove tumors. Either you can take them off with instruments, you can strip the wall of the inside of the abdomen where you can remove, like that picture says, you know, hundreds of tumors instead of just removing tiny amounts. Or sometimes you have to remove organs like the spleen, sometimes the gallbladder, other organs to get her all out. The second part is where we give the heated chemotherapy. So what you're seeing there is the diaphragm muscle was stripped. Okay. The second part is what you're looking at. That's where we give heated chemotherapy. We give it for 90 minutes. Basically, inflow and outflow tubes are connected, the abdomen is closed, and then the patient receives a continuous perfusion of heated chemotherapy. The idea is that, you know, with the surgery, there certainly were microscopic cells that we couldn't see, you know, or feel. So the idea of HIPEC, the heated chemotherapy, is to destroy those tiny cells, or at least help destroy them. Again, it's very controversial in stomach cancer. We use it commonly for other types of cancer. And the reason it's controversial is it's controversial because we don't have any great studies that have been performed in modern times to study it the right way. You know, we've done it for ovarian cancer, colon cancer, appendiceal cancer. For stomach cancer, we just don't have that robust data. But we're working on it. There are trials that are coming up. So it is, you know, that is definitely something that's out of the box. And it's certainly not what we normally do.
And that's why you're here, to think outside the box when somebody like Anna comes to the table. So along with HIPEC, you also removed Anna's stomach. Dr. Sun, some patients might even realize that's an option. It seems very drastic. I'm sure when you first heard that, but how is it possible to do that?
Yeah, the question is, as Dr. L. Kospos mentioned, that when you had metastatic disease, which means they spread out different way, when spread to abdominal cavity, so we call it peritoneal disease is spread. The question is, number one, the chemotherapy are not able to penetrating into peritoneal area. That's why the chemotherapy generally we use important, but their efficacy to the peritoneal is limited. Number 2 is the technical issues. You know, many hospitals are not prepared. Many surgeons are not able to do that. That require expertise and require the teamwork, which means you have the best medical oncologists, you have best surgical oncology, you have the best radiologists and pathology. To do that is not available in every small or middle-sized hospital. Has to be like a comprehensive tertiary care center like University of Kansas Hospital.
So, Anna, you hear this is an option, having your stomach removed. I'm sure you had many questions. What were they?
The first one was, can I live without a stomach? Because I didn't even think of that before. And yes, that was my best option at the time, and it worked out. I'm so thankful that Dr. Campistol decided that I was a good candidate and we could do this. And he was determined to get surgery done, and I was so thankful. And that gave me strength in the hardest moments, because it was hard, especially after chemotherapy. As Dr. Sun was saying, it was tough. But while we were in business, we were in Westwood, We put all we could to fight it. Once we were out, we tried to live as much as possible our life. I usually got sick a couple of days after chemotherapy, but then I was fine, and I could continue working or doing things and enjoying life, because I didn't know how long it was going to be.
So the recovery, tell us a little bit about that recovery, how long it took.
After surgery?
Yes.
Well, it took a few weeks, but honestly, for the big operation that I had done, it was really easy to go. They even sent me, they put everything they had in hand to make me get well as soon as possible. They sent me a nurse to my home, and she came only once because I was doing so well under the circumstances that they believe, I mean, she thought I didn't need her anymore.
You've been taking this in stride, Anna. Tell us, for those who have a stomach, what is it like to not have a stomach? What does it feel like day to day?
Honestly, Dr. Alcaspols did a surgery that on my daily basis, I don't notice the difference. The main difference is that I get full easily. Like I eat little amounts and more often, but that's mainly the main difference before and after surgery. And the main point is that now I am cancer-free, so this is much better to not have a stomach now than to have it before and not being able to be healthy.
So, Dr. Alcaspols, kind of help us draw a mental picture. She eats food. We all think it goes down the esophagus and through the intestines and or into the stomach. And tell us where it goes and how it gets out.
Yeah, you could imagine, you know, the anatomy is you have the esophagus, then the stomach, and then the small intestine. Now, the beginning of the small intestine has a certain name. It's called the duodenum. Well, basically, when she eats, things go to the end of the esophagus, and then they go directly into the small intestine. And what happens then, it meets the pancreatic juices and the bile, you know, the bile that comes from the liver at some point, and all of the digestion and absorption is done in the small intestine. And as long as, you know, this is like, basically, it's like bariatric surgery on steroids. Because basically, with bariatric surgery, the stomach is left in place, but they create a small pouch and do the same reconstruction. In her case, there is no pouch even. I mean, so she has to eat small, frequent meals like 6 times a day. She has to avoid certain foods, like things that are very sugary type foods.
But very little weight gain, you say. She should really maintain the same weight.
Oh yeah, I mean, she could. I mean, she has permission to eat, you know, as much as she wants. I know people love hearing that, but the reality is, she can eat whatever she wants as long as she's eating the right way and in small amounts. She shouldn't gain any weight, and you know, she looks good. She's, you know, that weight that. You know, that's the result you want, that weight. Yeah.
Dr. Sen, okay, let's keep the good news going. Anna is free of evidence of cancer, so we know no evidence of disease. But medically speaking, she's also getting what's called cancer surveillance. What does that surveillance entail for her?
Yeah, surveillance is very, very important for a patient like a major surgery because we did the chemotherapy, we shrink the tumor, and Dr. Alcaspols successfully took the cancer out and do those high pack. The question is, we always consider the cancer is not just the radiology, or I mean, we got a CAT scan, MRI, evidence of disease. So those are called a micrometastatic disease or microresidual disease, which the naked eye cannot see. So radiology cannot see. Those are circulation potential possible tumor. If it happens, we call it recurrent of disease. We want to kill those cells when they are not visualized yet. So today we have circulation DNA technology. However, we still need to follow patient very closely. We give people chemotherapy or immunotherapy after surgery, trying to kill those not visible yet, those are micrometastatic disease. And we'll continue doing this, periodically checking patient blood testing, CT scan, CAT scan, we call it surveillance, which is very, very important for prevent a tumor come back. And if some patient, unfortunately, disease may come back, we catch it early before even have any evidence suggests so. That's very, very important for everybody to understand. Surveillance after surgery is extremely important.
That is key. Anna, You're diagnosed with stage 4 cancer. You've gone through this whole story, this journey. How important has family and friends been to you? And we're going to show some photos of these very supportive, loving people.
Yes, we have felt all the love with family, friends. They came from Spain, they came from Andorra. They supported us, all our neighbors and our doctors. I think we all made a great team to get through this together and to do the best of it, which is not always easy, but we made it. And I always trusted my doctors, the patients. They know what they are doing. They kept me informed and reassuring, but at the same time, they gave me time to enjoy and to disconnect, which is very important.
So you had support here at the health system and at home. Your folks came over from Spain, is that right? How great was that?
That was awesome. That was fantastic. They all came for Halloween time, and we went to get candy.
Well, yeah. The best part, friends, your girlfriends, your tribe, so important. Tell us a little bit about them as well.
Wow, they have been also super. I mean, from the first day, we didn't know very much what was going on. Nobody could tell, and they were already trying to help, asking for anything they could do with the kids, with me. They did a meal train, and I don't know, every big step they would send flowers, or they would just get together to do something nice. So I would get a little bit more encouragement.
Yeah. They're all part of your story. Be sure to ask your questions. You can use the chat on YouTube, Facebook. You can tweet us or email us at the Medical News Network. The info is right there on your screen. Let's get a quick check of our COVID count. Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Good morning. How are you? Happy Monday.
I'm good. Happy Monday. Should be nice today. And it has been quick for the COVID count the last couple days. Very low active cases, so 8 total, only 2 active. Unfortunately, 1 in the ICU and is on the ventilator as well. So.
All right, Hawk, so during the height of the pandemic, more people took cleaning their bodies and their hands. You perfected the art of hand washing. You helped us really see the light of where we were and the more cleaning we needed to be doing. But there's a headline that suggests that we might be slacking on the hand washing and disinfecting. We're kind of back to our old habits. CDC data shows foodborne illnesses, those rates have returned to their pre-pandemic levels. We're talking about things like E. coli and Listeria, other things. Doc Hawk, why do you think these foodborne illnesses have rebounded?
Yeah, so I think it's a number of things. So certainly individually, it is extremely important, just as you said, Jessica, adequate food preparation techniques. So that definitely is hand hygiene, but it's also making sure countertops and utensils are cleaned before using one utensil, going from one piece, say raw meat or raw chicken, to another, say vegetables, and cutting those. So that's very important, is the food prep. Obviously the cooking time is extremely important, making sure you're cooking it as you should. And again, hand hygiene, vitally important. Those are the individual things, but there are also larger multifactorial issues, such as when the food is originally prepared or made for consumption, those kinds of practices, making sure that those decontamination practices at the production plant is good. And it's also continued surveillance and active surveillance when those food items are made ready for sale. So it is not only your individual, but it is national types of things as well. And you can only do so much. Certainly it is vitally important to pay attention to those individual things that you can do, such as, again, the food preparation techniques, but also hand hygiene. And as we move further into this and we have more population, obviously needing more consumable goods, we need to make sure that we have those surveillance plans in place, and that all of those food preparation or production places are doing what they should be from the FDA regulations to make sure that they can reduce contamination and illness as much as possible before even getting it to the consumers.
Thanks, Doc Hawk.
Yeah.
See ya. All right, any reporters with us today? All right, let's get to some great viewer questions. And Amy wants to know, does Anna have to take supplements to ensure that she's getting the right nutrition?
Yeah, that's a good question. Obviously, since she doesn't have a stomach, she has to take something called B12. It can either be injected, but you can even take it orally, so that's an important point. Sometimes the pancreas doesn't work right when you don't have a stomach. It just has to do with the way the pancreatic juices mix with the food. So sometimes you have to take pancreatic enzymes. And then there are times that, you know, since again the bile is getting to the food in a abnormal way, not natural, sometimes you have to take supplements that are like bile-like supplements. But really she just has to be focused on proteins mainly. Not too much sugar, especially the simple sugars, the ones we all like.
Boo,
yeah,
I
like
know.
candy and ice cream. Not too much. I mean, she'll figure out what works. She already
Right.
has, and then a little bit of fat. You can continue to add fat over time to your diet, but mainly it's proteins every 3 hours. And don't drink a lot of fluids with each meal. You want to drink a little bit and then wait about an hour and drink more fluids. So she goes. We have a dietitian that's part of the team that she works with, our dietitians are extraordinary. They've seen patients like Anna recover all the time, so it makes a huge difference. They're in the clinic with us.
Anna, that was another question for one of our viewers, just kind of what have been some of the biggest changes you've had to make or adjustments with your diet? Any challenges besides the sugar? Were you a sugar person before? Because that would be the toughest for me.
I think it's been fine. I can eat pretty much everything, drink coffee, which I didn't know if I could before surgery. I'm thankful for that.
Yeah, right?
Yes, I like coffee. But yes, I do a normal life, healthy. I eat as healthy as I can.
Anna, you just seem to be happy to be alive and doing well. And you're willing to make any adjustment it takes and listen to your good doctors. Marcia wants to know, she said her son's maternal grandfather died as a result, Dr. Sun, of stomach cancer. Should there be a concern of a genetic link? And what kind of testing can be done?
Yeah, so there are about 10% each patient that may have a family history of a gastric cancer, especially younger people. So that's important. If anybody have a family history of a gastric cancer, which means stomach cancer, looking for the medical genetic consultation, and those patients may have a family history of cancer, genetic testing can tell us. And just like Anna, we always recommend genetic testing. However, on the other hand, it's important, besides the genetic testing, we pay vigilant attention to this family member, especially when we have early symptoms, maybe ignored or consider as a common symptoms. Don't rely on it. Looking at your medical attention first, besides genetic testing. Both are very important to early surveillance.
Yan Liang wants to know, will patients who have had maybe gastric ulcers or have taken PPIs have an increased risk of developing gastric cancer?
There are some, we call it the reflex symptoms. They might have increased, and believe it or not, United States and European, we have younger people have this is called a GE junction cancer, which is between stomach and esophageal area. So if the symptoms of PPI or those medication does not work well, there is a very quick assessment you can do, which is endoscopy, we call it EGD, to talk to your doctor, talk to your especially gastroenterology to do those procedure. It's really, you can catch it very early, besides genetic testing, common sense, and a follow-up.
Couple more questions. Dr. Alcaz-Pools, and you touched on this, but Jeremy wants to know, how do the remaining organs adjust to accommodate the missing stomach? How do the other organs know how to play in there without that stomach?
Yeah, and that's a great question. You know, pretty much all the organs, it's incredible how they can adapt. And I would say there's very little getting used to. I think the biggest thing is the small intestine, because what happens is usually with the stomach, the food, especially the carbohydrates, they don't go into the small intestine right away. You know, they churn in the stomach for a while, and then they eventually go through. But when the small bowel is overwhelmed with a lot of food or foods with carbohydrates, the patient gets something called dumping syndrome. Dumping syndrome is like almost a hormonal response. It also has to do with, you know, about the concentration of sugar in the small bowel. But anyways, the symptoms are terrible. I mean, patient will have abdominal cramping, they'll have bad diarrhea, their face gets flushed. Some people even say it feels like you're dying. That's how serious dumping can be. And there are ways to get around it. One of them is diet, and the other are there are medications we can give for dumping. So it's really the small intestine that has to make the most adjustments, just handling what goes to it right away. That's a good question.
But Anna, being a good patient and following her diet probably helps too as well, right?
Yeah, and she's done an incredible work. She's her #1 advocate. She's awesome. Yeah.
Yeah, I think we see that.
Thank you, Dr. Alcaspol. You are.
Last question, though, from Tanya, is removing the stomach with stomach cancer similar to like a mastectomy with breast cancer? Is it the same? Is it the same type of theory where you remove something that may come back?
Oh, that's a good question. You could answer that. That's more of a medical oncologist.
Yeah, and when the cancer go to a certain level beyond you remove the cancer, because the danger is those are tumor cells circulation in the body like any other cells. So they're called metastatic. So the question is very important to have surveillance and management after surgery to control or destroy those micro metastatic disease, which means the naked eye, today's technology, we're not able to see them. So we need to wipe them out so to prevent those cells seeding somewhere to causing future troubles. That's very important.
The other thing is, you know, how we talked about that kind of spread, we call it peritoneal carcinomatosis. Stomach cancer is notorious, if it ever occurs, to come back that way too. So that's one of the reasons HIPEC is important, is because we feel like it addresses that surface better. So, you know, hopefully with the HIPEC treatment, you know, it could potentially prevent it from coming back that way, you know, that kind of spread. Yeah.
Quick last question. Sharon wants to know, can you still eat fruit?
Yeah, absolutely.
Okay.
Fruits, veggies.
Good. Inquiring minds want to know. All right, let's get our takeaways today. Dr. Sun, I'll start with you. What do you want folks to take away from our conversation?
It's really important is #1, you know, be sensitive to your body symptoms. And because you also remind your doctors working together, so that's a responsibility. Make sure your doctor understand, because when you present into doctor rely on your symptoms. And if it works, tell doctor. If it doesn't work, tell doctor. You know, so they can move to the next step or to look for expertise to look in the issue instead of relying on common symptoms. So that's very important. Second part is, when you have the disease, the best way is to go to expertise, because the technology is moving forward, medicine is evolution all the time. So go to the best hospital, tertiary care, because especially university cancers, it's the NCI designated cancer center. It's very important because all expertise are here. So the third part is after that follow up, listen to the doctor's advice, very important, because sometimes we consider we're done. It's not done. It's a long-term journey. Sure. So keep a patient as healthy as possible.
Dr. Alcaspol, take away.
Yeah, I mean, I echo everything Dr. Sun says. I mean, that's absolutely true. I think one of the things that happens, and I think Anna probably did this like everyone else does, they go on the internet, right, and they see things, and it's scary, and it seems, you know, gloom and doom. But the reality is the internet can give you, you know, some of it is true, there's no doubt about it, but the only way to know, the only information you can't get from the internet is the latest advances. That's the key, is that it doesn't have that information. And that's why you need to go to the doctors. Even though people think they can get that information, they can't. There's no other way to get it than to see their doctor, because they're the most up to date with that information. So internet, just use, you know, to a certain degree, grain of salt.
A grain of salt, and bring it and ask your questions to your doctors, the right doctors, as Anna would say. These are the best. Absolutely. And what do you want folks to take away from your story?
Well, cancer diagnosis is really terrifying, but you need to get strength from all your cells, your good cells in your body. Trust your doctors and follow the treatment. Even if it's hard, I know some people decide like, this is too hard. No, you need to get it done, and then it can be done. I mean, we have here an example, and I'm so thankful again for KUMed, Dr. Sun, Dr. Alcaspol. They have been amazing, like a second family to us.
Well, and we're grateful for you just to share your story with us today and just being so open. We thank you so much.
Thank you.
All right, thanks to all of our guests and to our viewers, of course, for being with us today. We'll see you back here Wednesday at 8. Coming up Wednesday on Open Mics with Dr. Stites.
Wegovy, Ozempic, and similar drugs are changing how patients approach weight management. I'm Alexis Del Cid. On the next Open Mics with Dr. Stites, how do the drugs fit into the bigger picture of weight loss, and what happens once the prescriptions run out? Wednesday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.